you said that you're interested in hearing the nutritionist dietitian's perspective about plant-based foods and their beneficial effects on the kidneys. With that in mind, I titled this presentation Plant-Based Diets and Kidney Disease. So it is my hope that after listening to this presentation, you will be able to describe different plant-based diets, understand the changing nutrition considerations at different stages of chronic kidney disease, list benefits of plant foods to kidney function preservation, recall suggested plant-based nutrition interventions for CKD, and appreciate the contribution of the registered dietitian nutritionist as part of the renal care team. I start with the references that I found relevant. Okay, so here are my sources, which are recently published, and the reference lists range from 34 to 193 references per article or report. So I'm not sure if you will be able to get hold of my slides, but this is being recorded, so I think it's easy for you to check out the different articles and resources. One of our patients gave my colleague a copy of this book, which I bought and read in preparation for this presentation. There's also a version for the patient as well. Okay. Studies agreed that plant-based nutrition lifestyles are healthy, suitable for all phases of the life cycle, and have been linked to a lower risk of chronic diseases, including kidney disease. Examples include whole food plant-based, as opposed to refined or processed plant foods, while avoiding animal-based foods. You have vegan, which is 100% plant-based, the lifestyle that also avoids use of products derived from animal sources. Then you have their lacto and or ovo-vegetarian, which may include dairy and or eggs. Then you have pesco-vegetarian. Occasional fish or seafood is included in the diet. Now we have flexitarian, occasional intake of meat and animal products. Then you have the DASH diet, which stands for Dietary Approaches to Stop Hypertension and Mediterranean Lifestyle. So these are plant-based while allowing small amounts of animal-based foods, such as lean meat and low-fat dairy. The Mediterranean diet or lifestyle also incorporates moderate use of seafood and olive oil through both lifestyles. Though both lifestyles emphasize the use of unprocessed foods and avoidance of refined foods. Then you have there the Play-Doh diet. This is a plant-dominant, low-protein diet of 0.6 to 0.8 gram per kilogram body weight for patients with kidney disease. This consists of less than 50% protein from animal sources, and this is high in dietary fiber. The definition of plant-based diets encompasses different dietary patterns that share the trait of an increased intake of plant foods and the limitation or absence of animal foods. It would be useful to have a more precise definition of these diets, especially in terms of the amounts of animal products and ultra-processed foods that they allow, because not all plant-based diets are equal. Findings from the chronic renal insufficiency cohort study published in May 2024 included the comparison of the effects of healthy versus unhealthy plant-based diet. Healthy plant-based diet included whole grains, fruits, vegetables, nuts, legumes, tea, and or coffee. Okay. The unhealthy plant-based diet included fruit juices, sugar-sweetened beverages, refined grains, potatoes, sweets, and desserts. So the results of this study, a healthy plant-based diet was associated with a lower risk of all-cause mortality. By contrast, following an unhealthy plant-based diet was associated with a higher risk of CKD progression and all-cause mortality. These results suggest that the quality of plant-based diets may be important for CKD management. Okay, so the ideal plant-based diet for CKD prevention can be described with these two main traits: minimal or no animal foods to reduce acid load and phosphorus, and minimal or no processed unhealthy plant foods to reduce sodium, phosphorus from preservatives or additives, and empty calories. For a refresher, here are the stages of CKD and the progressive changes in kidney function. Most of you, if not all of you, are familiar with this. So you have there from mild kidney damage in stage 1, where the kidneys work as well as normal, and most probably the patient does not know that they have any problems with their kidneys, to stage 5, where most severe kidney damage is already affecting the patient. Kidneys are very close to not working or have stopped working or failed. Unfortunately, some patients, because they have not gone for their annual checks for a long time, they find out that they have kidney damage really very late because all the symptoms are out, and they most probably found out because they had to rush to the emergency room and get hospitalized. Okay, I want you to check this slide out. The blue boxes above are the risk factors and the stages in CKD, while the green boxes below are the nutrition interventions and considerations in CKD. As chronic kidney disease progresses, the requirements and utilization of different nutrients change substantially. These changes lead to multiple nutritional and metabolic abnormalities. The benefit of nutrition intervention is to slow CKD progression and avoid or delay end-stage renal disease. When renal replacement therapy will be needed to survive, right? And the renal replacement therapies and accompanying medications are very costly. It's costly here in the United States, but I think it's more beyond the reach of many in the Philippines due to lack of health insurance. Not everyone who needs them can afford treatments for the long haul. Thus, it is expedient to prevent and/or slow progression of CKD to end-stage kidney disease or renal disease. Nutrition intervention for people with CKD varies depending on the stage of kidney disease, treatment modality, and comorbidities such as diabetes, hypertension, and cardiovascular disease. Nutrition therapy is individualized with the help of a qualified registered dietitian nutritionist in the US, and I think in the Philippines, it's registered nutritionist dietitian. Nutritional factors play an important role in the development of CKD and its progression, and certain dietary modifications may have a favorable impact on important clinical outcomes. We will revisit this slide towards the end of this presentation. In the past, we promoted high biologic value proteins, mainly from animal sources. And then we also identified whole grains, legumes, and seeds as foods to limit or avoid due to their high potassium and phosphorus contents. We made sure to call out fruits and vegetables high in potassium to prevent hyperkalemia or whenever serum potassium goes above reference range. Thanks to continued research, studies, and reviews, we have periodic updates in our clinical practice guidelines. I'll share the most recent ones relevant to our topic. The following recommendations were released in 2020. I highlighted protein, phosphorus, and potassium updates. For protein, the food source does not matter anymore because there is insufficient evidence to recommend a specific type of protein, whether animal or vegetable. For phosphorus, it is reasonable to consider bioavailability of phosphorus sources when applying restriction, and we'll see more of this later. For potassium, it is reasonable to adjust dietary potassium to maintain normal serum range. In hyper or hypokalemia, suggest that dietary or supplemental potassium be based on individual needs and clinical judgment. Okay, for recommended protein allowances, it is an established fact that populations in Western countries consume an excess of the minimum daily protein requirement, which is 1.35 grams protein per kilogram per day in the Western societies, compared with the daily needs estimated to be only at 0.8 gram protein per kilogram per day. From the Kidney Disease Outcomes Quality Initiative, or KDOQI, guidelines released in 2020, see here, for later stages of CKD, not on dialysis and metabolically stable patients, the recommendation is a low protein diet of 0.55 to 0.6 gram per kilogram body weight per day, or a very low protein diet of 0.28 to 0.43 grams per kilogram body weight per day with keto acid analogs to meet protein requirements of 0.55 to 0.6 grams per kilogram body weight per day. For those with diabetes, it is reasonable to prescribe 0.6 to 0.8 gram per kilogram body weight per day to aid in optimizing glycemic control. For CKD stage 5 on dialysis, maintenance hemodialysis, and peritoneal dialysis with or without diabetes, a higher amount of protein is required at 1 to 1.2 gram per kilogram body weight per day due to the losses that the patients experience, protein losses as a result or consequence of dialysis. For management of acid load in CKD 1 to 4, the suggestion is to reduce net endogenous acid production through increased intake of fruits and vegetables to reduce the decline of residual kidney function. Okay, so let's go to the benefits of CKD shown by studies. These are the supporting evidence for the updates in the guidelines. Okay, so vegetable proteins have a lower effect on kidney hemodynamics than animal proteins, reducing renal load and hyperfiltration. This effect may act synergistically with the pharmacological effects of RAAS inhibitors and SGLT2 inhibitors. Plant-based low-protein diets have a reduced acid load and counteract the onset of metabolic acidosis. Rich in fruits and vegetables, they have an alkalizing effect. Animal foods promote non-volatile acid production, which is what we call the endogenous acid, due to organic sulfur found in amino acids and is oxidized to sulfate. Natural alkali found in plants converts to bicarbonate. Plant-based diets have a more favorable lipid composition. Plant-based low-protein diets can improve the lipid profile in CKD. Plant foods contain phosphorus in the form of phytate, which is poorly bioavailable. Consequently, there is less intestinal absorption of phosphate and better control of phosphate levels using fewer drugs or using fewer phosphate binders. Check out this infographic showing the low bioavailability of phosphorus from plant-based foods. With new evidence, our nutrition counseling and instruction changed from limit or avoid foods high in phosphorus, which includes legumes, nuts, and seeds, right? We shifted from that to limit or avoid processed foods, especially those with phosphate additives. We now encourage eating plant sources more and less animal sources of protein. More of the evidence. Plant-based low-protein diets provide high amounts of fiber and vitamin K1, which, in association with lower levels of phosphorus and reduced risk of metabolic acidosis, could have a beneficial effect on vascular calcifications and bone health. Plant-based diets can increase intake of magnesium, which may have additional beneficial effects in counteracting vascular calcifications. Plant-based diets counteract the state of insulin resistance typical of patients with CKD and improve blood pressure control. Plant-based diets generate fewer uremic toxins, reduce proteinuria, and temper GFR decline through a variety of mechanisms other than simply a reduction of protein intake. And this includes alterations in the microbiome. Plant-based diets favorably shift gut bacteria from a proteolytic profile to saccharolytic one, and consequently promote short-chain fatty acids, strengthen intestinal barrier integrity, which counteracts bacterial translocation, reduce inflammation, and improve immunity. This shift in turn reduces production of key uremic toxins shown to promote CKD, including p-cresyl sulfate, indoxyl sulfate, indo-3-acetic acid, and trimethylamine N-oxide. Uremic toxins are associated with animal protein intake and favor growth of proteolytic bacteria in the gut microbiome. And TMAO is a biomarker of CKD and CVD. High fiber intake is known to improve glycemic control, weight control, and the lipid profile. Fiber intake in CKD helps lower urea and creatinine levels. Urea alters the gut microbiota composition, resulting in dysbiosis. High fiber plant-based diet is highly involved in the maintenance of eubiosis and provides antioxidants necessary in mediating chronic inflammation. Fiber intake reduces serum urea levels by promoting fecal route of excretion for nitrogenous waste. Fiber intake has a laxative effect which counteracts risk for hyperkalemia. Vegetable foods compared to animal foods are rich in phytochemicals known to be protective of the cardiovascular system and have a higher capacity to neutralize free radicals, which are cancer protective. For example, cruciferous vegetables, turmeric, beetroot, garlic, and berry fruits have antioxidant and anti-inflammatory effects. Bioactive compounds from plants have been proposed as a non-pharmacological strategy to reduce inflammation and oxidative stress. We have more. Vegetable foods compared to animal foods have a lower content of AGE, or advanced glycation end products. Patients with CKD often have high levels of AGEs because endogenous formation is increased due to oxidative stress, and their renal excretion is reduced. Therefore, a reduced intake of AGEs in the diet may have positive effects, especially in CKD. Vegetable foods have lower content of persistent organic pollutants compared to animal foods. Examples of these POPs are dioxins, furans, polychlorinated biphenyls, organochlorine pesticides. These compounds tend to accumulate in animal fats through the so-called bioaccumulation, and they may be associated with kidney damage. A vegetarian diet can cut the risk of kidney stones by half. According to some research, a balanced vegetarian diet may reduce the risk of kidney stones compared to a meat-based diet. A diet with a high intake of fruits and vegetables can help maintain an alkaline urinary pH, which can reduce the risk of uric acid crystallization and kidney stones. A diet with low animal proteins and high fluid intake can reduce the risk of uric acid crystal formation. A balanced lacto-ovo vegetarian diet that includes adequate calcium and oxalate intake may help prevent kidney stones. This can be achieved by inclusion of low-fat dairy products. Other tips to avoid kidney stones include staying hydrated, cutting back on salt, increasing citric acid intake by adding lemon juice to water, moderating caffeinated beverages, and drinking an extra glass of water with them. So, what about quality of life and economics with plant-based diets? So, let's see. Dialysis represents an invasive therapy that reduces quality of life and productivity. And in the elderly and patients with comorbidities, dialysis may not be tolerated. I see this all the time. I have been working with dialysis patients since 2011, and life is not easy. I do not wish anyone to get to that point if preventable. It is, though, a lifesaver and a life extender, especially for those who were born with congenital disorders affecting the kidneys, and those with untreatable, untreatable disorders that lead to kidney damage. But if we can prevent getting there through lifestyle change, why not? It's not an easy life, and it is a very expensive life to lead, living in dialysis. Very low protein diets can counteract uremic symptoms and delay renal replacement therapy for patients who wish to postpone or avoid dialysis for psychological or clinical reasons. For example, while waiting for maturation of vascular access to start dialysis, or a preemptive transplant program, or the start of palliative care. In some cases, the poor palatability and the high cost of protein-free substitutes can make compliance with very low protein diets difficult. And in that case, a vegan low protein diet may be a better option to improve adherence and satisfaction. Economic analysis also supports the use of a vegetarian very low protein diet plus keto acid analogs to prevent CKD progression and postpone dialysis as a cost-effective approach with beneficial effects for patients and healthcare costs. We've looked at the benefits of plant-based diets. Now let's focus on the concerns. Amount of protein. Plant-based diets often contain less protein than omnivorous diets, but they are not low in protein per se. Protein intake as percentage of total energy intake for meat eaters is about 17.5%. Less for fish eaters, then less for lacto-ovo vegetarians, and least for vegans, which is about 13% of total energy intake. All of these, including the vegan protein intake, all of these are above the British recommendation of 9% and American recommendation of 10% of total energy intake. Next is quality of protein. It is known that all plant foods contain all 20 amino acids, including the 9 essential amino acids. However, the amino acid distribution profile appears to be less optimal than that of animal foods. But in many cultures, foods are consumed in combinations. Eating a variety of plant foods, including mixed sources of proteins, makes covering all needed amino acids achievable. Plant protein-rich foods such as traditional legumes, nuts, and seeds are sufficient to achieve full protein adequacy in adults that follow a vegetarian or vegan diet, while concerns about any amino acid deficiency have been substantially overstated. In kidney patients, it has been shown that a vegetarian low-protein diet with a protein prescription of 0.7 to 0.75 gram per kilogram body weight could meet the requirements for all essential amino acids in the absence of a deterioration in nutritional status. Previous studies have shown that when metabolic acidosis is corrected and energy intake is adequate, patients with advanced stage CKD can fully adapt to low-protein regimens, and that they can maintain a neutral or slightly positive nitrogen balance with protein intake as low as 0.55 to 0.6 gram per kilogram body weight. Even the very low protein diet of 0.3 to 0.4 gram per kilogram body weight, supplemented with keto analogs to reach a protein intake of 0.55 to 0.6, does not seem to be correlated with the onset of malnutrition and does not lead to an increase in mortality in patients who subsequently start dialysis. Hyperkalemia. Emerging data indicate that dietary potassium may be beneficial for patients with CKD. Studies have shown that higher urinary potassium excretion, which correlates with higher dietary potassium intake, is associated with lower blood pressure and lower cardiovascular risk in CKD patients and better kidney outcomes. It seems that increasing dietary potassium may be equally as important as reducing sodium intake. Recent studies reveal that dietary potassium promotes sodium excretion. There is limited and inconclusive evidence regarding association between dietary potassium intake and serum potassium in patients with CKD. Despite a lack of conclusive evidence, restricting dietary potassium has historically been recommended for CKD patients to prevent hyperkalemia, which can cause severe arrhythmia leading to death. This has been my experience and the experience of all of us, just because the guidelines before were geared towards just reducing potassium intake. Not even thinking of all the other things behind it that can be happening inside the body and not influenced by potassium intake from foods. Restricting dietary potassium often means reducing healthy plant foods in the diet. This can deprive patients of the potential benefits of high dietary potassium intake for kidney function decline, end-stage kidney disease, and cardiovascular disease events. Potassium from animal food sources is associated with a simultaneous intake of acid load, which can predispose patients to the development of metabolic acidosis and consequent hyperkalemia. On the contrary, intake of potassium from plant foods is associated with an alkalizing effect and with the intake of fiber, which reduces the risk of constipation, and intake of carbohydrates, which stimulate the release of insulin and the consequent entry of potassium into cells. All these can reduce the risk of developing hyperkalemia. Current strategy suggestion is to reduce dietary potassium intake only in the presence of documented hyperkalemia and after excluding and correcting other possible causes, such as metabolic acidosis, uncontrolled diabetes, and constipation. And then The first foods to be restricted are those that are both rich in potassium and unhealthy. For example, fruit juices, potato chips, chocolate, sauces, etc. If hyperkalemia develops, new potassium-binding medications should be considered rather than discontinuing the healthy plant-based diet. The bran and germ in whole grains have unique health-promoting bioactive components and provide more B vitamins and fiber. Phosphorus is present as phytate, which is not digestible in the human gut and so does not contribute to dietary phosphorus load. Whole grain consumption in the general population has an inverse association with the risk of type 2 diabetes, colorectal cancer, and cardiovascular mortality. This is also true with fruits and vegetables. Whole is preferred over juice or highly refined forms of these plant foods. Vitamin B12 deficiency is a growing problem in the general population, especially among elderly people. Supplementation with vitamin B12 appears essential to plant-based diets since this vitamin is only contained in animal products. On top of this, all CKD patients are at risk of deficiency due to reduced absorption, due to the low intake of animal products in a low-protein diet, and due to the simultaneous intake of drugs affecting absorption. Vitamin B12 deficiency can lead to vascular damage, neuropathy, and cognitive disorder. I found this vegan sample plate for kidney health. Imagine replacing less than half of plant protein with some low-fat dairy or fish or egg. The diet can still be plant-based or plant-dominant. Here's an overview of the plant-dominant low-protein diet, or Play-Doh, for nutritional management of CKD based on a total dietary intake of 0.6 to 0.8 gram per kilogram per day, with greater than 50% plant-based sources, preferably unprocessed foods, relatively low dietary sodium intake of less than 3 grams per day, and higher dietary fiber of at least 25 to 30 grams per day. Adequate dietary energy intake of 30 to 35 calories per kilogram per day. Weight is based on the ideal body weight. Note that serum vitamin B12 should be monitored after 3 years of vegan diet. Let's see an example. For a CKD stage 4 patient with body weight of 50 kilograms, the recommended diet is low in protein. That is 0.6 to 0.8 grams per kilogram, which is equal to about 30 to 40 grams of protein per day. Here are examples of protein-rich foods, plant foods, and their protein content. See there, chickpeas, half a cup of chickpeas, cooked chickpeas will give you about 8 grams, black beans, 7 grams, regular tofu, 11 grams, firm tofu, 21 grams protein, cooked whole grain rice, half a cup, 3 grams, half a cup of boiled sweet potato, 2 grams, and 1/4 cup of peanuts, 9.5 grams. Play-Doh recommendation of less than 50% of protein intake from animal sources, just because the recommendation is greater than 50% from plant sources. That will give us about 14 to 19 grams coming from animal sources. Here are examples of animal foods and their protein content, just to give you an idea of how you can mix, but still maintaining the diet being plant dominant. Here are proposed strategies to improve the nutritional value of vegetable proteins. Creating diets containing different plant protein sources to provide a high-quality amino acid profile, adding small quantities of animal protein to the diet, supplementing with essential amino acids or keto analogs, consumption of greater amounts of plant protein. Plan a diet based on a wide variety of plant foods, which should include pseudo-cereals, whole grains, legumes, and nuts. I was not familiar with the term pseudo-cereal, so I checked it out. So this is what I found. You have amaranth, buckwheat, chia, quinoa, and all the health benefits. I know these food items, they're available to us here in the United States. I'm not sure how common and affordable they are in the Philippines. So I searched for pseudo cereals grown in the Philippines, and this is what I found. I don't know if you're familiar with this, but it's kabog millet. For specific plant foods locally available in the Philippines, I tried to search for the FNRI food composition table online. That's the Food and Nutrition Research Institute. This was what we used in college in the mid-1980s when I was doing my bachelor's in nutrition and dietetics at the former PUC, Philippine Union College, now Adventist University of the Philippines. Well, I found one list, but not easily accessible, one listed, I should say, online. It seems that the latest edition of the food composition table there is from 1997. That's what I found. Then I found this, the CKD Nutrition Manual published by the Philippine Society of Nephrology, copyright 2018. I'm not sure if there is a more recent edition. It is an impressive manual, attractive, easy to read, and comprehensive, covering CKD 1 to 5, dialysis, and kidney stones. I checked the food lists for potassium and phosphorus. I found a few tropical fruits and vegetables in the lists, but the references were of foreign publishers also. Morrison Management Specialists and the US Department of Agriculture. So I decided to give you a homework. This is your homework. And that is to find or generate a good list of Philippine fruits, vegetables, grains, seeds, and nuts with their food composition information, including protein, potassium, phosphorus, carbohydrate, and fiber contents per serving. The product will be very useful. Once you create this, it will be very useful and helpful in the nutritional management of CKD patients. Please send me a copy. I will appreciate it very much. I think we covered the benefits of plant-based diets in CKD and principles of nutrition management. The most important aspect of plant-based nutrition is its protective mechanisms as a powerhouse in fighting inflammation. Fruits, vegetables, and legumes contain the bioactive compound necessary for fighting inflammation and provision of human health benefits. Eaten adequately, they help prevent CVD and stroke and decrease risk of CKD progression. Having said that, I'd like to add to the list of CKD risk factors, animal-based diet and exacerbated by presence of highly processed foods. What do you think? I hope you agree. Other considerations, DM, coumadin warfarin consistent, kidney stones, grapefruit and other foods that interact with medication, star fruit with its caramboxin that is toxic to the kidneys, and food allergies. Nutrition care tips. In closing, here are the tips in providing nutrition care to CKD patients. Individualized management. One size does not fit all. For each patient, nutrition needs change with the different stages of CKD. The goals of nutrition intervention are to slow progression of CKD, delay need for renal replacement therapy, at the same time identifying and preventing malnutrition and nutritional deficiencies. For example, the need to supplement to prevent vitamin B12 deficiency. Both of the previous items require professional and specialized nutrition care delivered as medical nutrition therapy. Referral to a registered dietitian nutritionist or registered nutritionist dietitian, preferably one with renal specialty, is important to improve diet adherence and optimize foods eaten in terms of variety and nutritional quality. The renal dietitian will focus on quality of life and patient goals. Inclusion of plant-based meat alternatives in the diet, those made with legumes and low in sodium, may increase adherence and improve quality of life. As the source of nutrition counsel and expertise, the renal dietitian will work with the interdisciplinary care team. Patient education contributes to patient motivation and empowerment to make lifestyle and dietary changes that can benefit the kidneys. So that's it. Thank you very much for your attention. And